Well, welcome everyone to our virtual Road to Residency event. This is a bonus webinar episode catered towards, first year students, second year students, and even pre-meds. But of course, everyone here is welcome to join in. We have a couple questions that we'll go through. We'll definitely make sure to allow time for chat questions, as well as people to bring up questions as we go as well. I want to start by just introducing myself and the rest of the panel. And then we will go into some questions regarding like intro to PM&R, what is the field? And then the second half or the latter half of the webinar will be focused on how can students become involved in the field as a first and second year. And then lastly, like I mentioned, we'll address all those pre-submitted questions if they haven't been addressed already, and then open up to open questions and chat questions. I have several of my other MSc members helping me man the chat and just make sure we keep our timing, because I know sometimes we can get ahead of ourselves, so we want to make sure we cover all the topics. If I haven't met you before, my name's Elise. I am a fourth year medical student, obviously applying or have applied to PM&R at this time. I'm the Education and Wellbeing representative on the Medical Student Council. I want to allow my attending panelists to first introduce themselves. If you don't mind just saying your name and where you're from.
I'm Dr. Russo. I'm a brain injury attending at Kessler, and I serve as the Associate Program Director for the Brain Injury Fellowship there.
I'm Dr. Brahmbatt. I am the outpatient VA SCI attending. That's also the Associate Program Director at the University of Louisville's SCI Fellowship.
Welcome attendings. And then we'll start with our residents. Starting with you, Dr. Landry.
Hi, everybody. My name is Melina, and I am a current PGY3 at Texas Rehab. I'm the current academic chief and also the education and well-being representative for the Resident Fellow Council.
Thank you. Dr. Sun.
Hi, everyone. My name is Melissa. I'm also a PGY3. I'm at Penn State. And I'm also on the wellness committee of the Residency Council, AAP. And at Penn State, I'm the QI champion within our residency.
Awesome. Dr. Nguyen?
Hey everyone, how's it going? My name is Eric. I'm a PGY2 at Charles University, new program out in Los Angeles from Irvine, California, and part of the AAP Resident Fellow Council for the Wellbeing Committee.
And then the rest of my MSc, do you guys want to introduce yourself as well?
Hi, everyone. My name is Annie. I am a third year at Penn State, and I'm part of the Education and Wellbeing Subcommittee for the MSc.
Yeah, hi, everybody. My name is Joel. I'm a third year med student at UCSF and also part of the Med Student Council, along with Elise and Annie.
Great. And then I don't know if Natalie's logged on yet, so we can start getting rolling with the questions. So welcome everyone, and thank you guys for coming. We'll start with some of our intro to PM&R questions. The first one being, how do you describe PM&R as a specialty in 1 to 2 sentences? And what examples of your work do you share when you're explaining PM&R to people outside of medicine? We can start with attendings, yeah.
Yeah. So I, in general, would describe PM&R as a whole person field. We really are focused on sort of the person in their context and how we can sort of optimize their function and well-being within their context. An example I would use, I'm a neurorehab doctor, brain injury doctor. So what I would use is that, a stroke neurologist in follow-up, you may go and say, okay, continue taking your aspirin and your statin. For me, in my field, we're going to be, I focus on are things like getting you back to your life roles, getting you back to work or driving. So really the kind of, how do you get somebody who's, had a neurologic injury back to full life, rather than sort of just that little medical piece.
Great.
I also do neuro rehab, and so for brevity reasons, I will just say the exact same as Dr. Russo. Essentially, our the way I describe PM&R is, we're function focused, right? So we're trying to get individuals to back to baseline function that they had prior to injury. And so I see specifically spinal cord injury patients, but BI, SCI, all these are very traumatic things, but our focus is on you've had something traumatic happen to you, but life does not end. It's just changed. And so we're focused on how can we adjust to that change.
Great. And then maybe from one of our residents too.
Yeah, so when people normally ask what it is you do in your field, so focus on brain injury, stroke, spinal cord injury, and really impairments, anyone with a physical disability. And our goal and our focus is to maximize their independence despite these illnesses or impairments that they have. And we're really caring for the whole person. It's a multidisciplinary and collaborative field where different specialties and different disciplines work together to make it happen. So.
What kind of along with that, what typical misconceptions do you commonly hear about PM&R?
I think there's just a general lack of awareness of PM&R and sort of our, other medical fields. Or if they know about it, they maybe know sort of the MSK side of things, but don't realize this full breadth of the disciplines that we have within PM&R. So it's pretty broad field, and we cover a lot of range with both general and subspecialty care. So it's I think for me, it's just this lack of awareness of sort of the field itself.
Mm-hmm.
I think everyone kind of jokes about, they've ran into situations when you say you're a physiatrist or a rehab doctor, and they're like, oh, you're a therapist. Can you teach me exercises for this? And so, I think there is that, I think that misconception is decreasing. But that's something I think tends to sometimes come about, as well as kind of not understanding the breadth that I think Dr. Russo was talking about. So, especially for medical students, I mean, you can go from intensive neurological deficits from severe strokes, traumatic brain injury, and SCI to, in residency, seeing a 55-year-old weekend warrior who's got knee pain from running marathons for 10 years, so you don't necessarily just see one thing. And so I think from a early learner of the field, sometimes you can kind of pigeonhole yourself into thinking that PM&R is this set thing, but there's really a quite expansive range that we cover, and that's why there are so many sub fellowships that you can do in PM&R. I think there's 7, if I'm counting kind of the major ones.
I think on the kind of flip side, you hear people also say, oh, PM&R, you're in the field of plenty of money and rest. And we do work hard as much as anyone else in any other field. And I think as a group or as a whole, we tend to seem like we're more relaxed and we enjoy our job more, but it's hard work.
I had not heard that, Dr. Landry. Plenty of money and rest. That is, nope, not my life. But I appreciate that that's out there. It's a cute acronym.
And kind of to just go along with everyone else's statements, but sometimes on the inpatient side, when we admit a new patient who hasn't been into an acute rehab before, I like to kind of explain that we work with all the therapists that you'll see on a daily basis, but we're kind of like the quarterback, kind of touch and go in between all the different therapists, the caseworker, and kind of managing a lot of different things, which I think sometimes makes a more simple comparison for someone who's not in medicine who can understand. So I feel like using that analogy with the patients coming into a new acute rehab has been useful in my experience.
And then I think just the spelling, sometimes people think it's psychiatry. So you have to look out for that too.
Oh yeah. My favorite spelling is when they put PMN, like the letter N.
Yeah. Yeah. And it's not PM&R, right? PM&R. Yep. Good. Well, we begin to kind of tend towards this question, and I think the residents might be well suited to answer this just because you guys do go through different rotations and see the whole gamut. Can you kind of run us through what a typical day would look like for a physiatrist? And we'll start on the inpatient side, and then we can kind of talk about outpatient.
For our program, our inpatient is relatively similar, I guess, to how an IM floors rotation would run. You kind of go in around 7:30, 8, do a little pre-charting. I guess the major difference is we don't pre-round before we actually round. So we'll do kind of like our pre-rounds on the computer, kind of check in with all the vitals, the sign-outs from our on-call team, and then we'll round for anywhere from 2 hours in the morning, and then kind of in the early afternoon finish up our notes, progress notes from the day, and then start prepping our admissions that we'll normally get in around 11 to 12. We normally get notified of the start of our admissions list then. And then the way that our rehab does their interdisciplinary team meetings, we have each attending will have one day throughout the week. So there'll be one day throughout the week that's the same time every week that you will essentially talk about all of your patients, their dispo, talk about how they're doing in therapies, any equipment that they might need. So that's quite unique to PM&R. I would say within the inpatient setting, you don't really experience that in any other specialty, which I think I really enjoy IDTs just because I feel like you get the tea and the gossip from a lot of the therapists and a lot of the social stuff that you don't really get to learn in a 10-minute interaction with the patient every day. Yeah, and then that's kind of it. Prep your admissions and then finish up all the last minute things and then sign out to the on-call team starting at 5 for us. And then our on-call team will start 5 p.m. to 8 a.m. And then it's just Monday through Friday. And then our on-call team also does their weekends coverage as well.
Anything any of the other residents would add to kind of a day on the inpatient side?
I would just say that the field varies a little bit in how it's practiced as far as inpatient goes. In some institutions, the PM&R doctor is the primary attending for their service, which is the case where I am. So we have sort of full overview responsibility where we can pull in consultants like internal medicine or cardiology or pulmonology if they're, any version, infectious disease, whatever. If there's something we need help with, but on a whole, in my institution, we're responsible for the patient's care start to finish. In other places, the PM&R doctor may be the consultant on the inpatient unit rather than the primary attending. It may be, this may be under medicine as the primary, and then PM&R comes in and consults. So the role is a little bit different institutionally, depending on where you work. For me personally, I preferred to be the primary attending and so I chose a job that allowed me to do that.
I will note we are primary, so that's why we have to do all the admissions and everything.
And then Dr. Russo, you kind of started towards this, but do you mind just kind of highlighting like the different types of like inpatient that a physiatrist might be in, for instance, like, like consult versus like an acute rehab, et cetera, and where that falls in the patient's sort of recovery timeline?
Yeah, so Okay, so you could, as far as inpatient goes, most of the inpatient physiatrists you're going to encounter are sort of the acute rehab level, where it's a 24-hour doctor coverage. It's intense rehab, 3 hours of therapy a day, level of care. And again, it's the distribution between, like, if you're attending of record versus a consultant are different. But when you're in that acute rehab, the physiatrist plays a pretty large role in sort of the management of the patient's care. You can have consults in a hospital where you might be called into, and that can be subspecialized in the hospital as well. My brain injury colleagues may be consulting on, brain injury patients in an ICU setting to help start their recovery from the very get-go. Or they may be on a more general consult service where they're really being asked for dispo recommendations. Is this patient appropriate to go to acute rehab, or should they go to a subacute rehab? The subacute is a lower level of care. It has less doctor oversight, so it doesn't have as much of the medical piece. And then the therapy is more limited. It may be an hour a day. It's less, and those stays tend to be a little longer than the acute rehab. And then, or they may say, okay, if the person's okay to go home, they can do, follow up as an outpatient, do outpatient, more home services, whatever. So, and then there are attendings who do consultations at subacutes, where they may go in and see a large volume of patients with less frequency, and they're might be there for spasticity management for those patients, or pain management, a combination of those things. That tends to be less direct involvement in the patient care, really more of a consultant role to come in and kind of just manage some certain things. But our home, I would say our inpatient home is sort of in the acute rehab setting, whether that's a unit in a hospital or it is a standalone facility where it's a separate building, separated from the main hospital. I have done both. I trained in a standalone, I worked in a hospital setting, and then or for my fellowship, and then back to I work in a standalone now. And there's pluses and minuses, because when you're not connected to a hospital, your resources are a little bit different than when you are physically in a hospital where they have CT scanners or MRIs or whatever it is that you might need more ready access to. So a little bit different practice.
And I think that begins to kind of speak to the medical acuity of the patient, right? Like if you're getting to the point where they're allowed to be in a unit not connected to the hospital, you're hoping that they're healthy enough to participate in therapy all day. And great. And then should we kind of move on? What would like an outpatient kind of day look like for a physiatrist?
I can speak on that. So I'm in my general MSK month, and so for me, my days go from like 8 to around 5:30 when I finish notes. But basically, I'm at the VA, and so we'll have 30 minutes for follow-up patients, 45 minutes for new patients, and so each day we can have up to 10 to 12 patients or even more. And it'll range from anything from neck pain, back pain, peripheral joints like shoulders, knees, hips, ankle, wrist pain. So you're doing evaluations for general MSK, half days we were doing EMGs, where we're doing electrode replacements with our attendings, nerve conduction studies, EMGs. Some half days we're doing actually mobility evals. So you'll see a patient needs any durable medical equipment to optimize their function. Some need AFOs, foot orthoses, and just depends if you power wheelchairs, things like that. So it's a good range even in the typical general MSK. So it's been fun being able to transition a lot after the tenure, and yeah.
And I guess on the outpatient side, separate from the MSK sports world, it really depends on, I guess, what type of patient population you have. Like I'm sure Dr. Russo and Dr. Brahmbatt have a lot of TBI follow-ups. I'm not sure if you guys do actually outpatient, but if you were an outpatient clinic, you would have a lot of traumatic brain injuries in general. And there is kind of different things that you look at on the outpatient setting once they get discharged from an acute rehab or a SNF or something like that. And then the spinal cord injury, our attendings, our clinics look very different depending on which attending that you're working with. And there's just different things that you want to follow up with each patient population. And we do a lot of Botox for spasticity in our clinics as well. So that's one of the procedural things that'll often be kind of put in as well. And then our EMG is kind of separate. So some attendings will have specific EMG days where they'll only do EMGs, or they'll go to a separate clinic. So there's kind of like a large breadth of things that you can do and see in PM&R, both inpatient and outpatient, which is really nice if you like variety. But yeah.
And the only other, the only other caveat I would add to all this is we've kind of put it into silos of inpatient, outpatient, and consult. And so one thing is, and that it's as Dr. Sun was talking about, it's dependent on what you want potentially as well. There will a lot of times be where you're doing multiple of these different silos in the same week, sometimes same day. And so it just depends on where you're practicing. I would say oftentimes it's very common just to get a combination of at least two of those three.
Yeah,
I agree. I would say we sort of touched on the procedural aspect of it. So there are a number of different procedures that we do across the spectrum. So, sort of injections of all sorts in various joints for sort of general pain management. She talked about spasticity management. We do a lot of the sort of BI and SEI docs do a lot of spasticity management as an outpatient. That comes in a couple different flavors, from Botox to nerve blocks, and cryo neurolysis is coming into fashion now too. We also will manage backlift pumps and refill them and program them as another procedure we do. And then from the pain side, again, there's between the sports and the pain, there's a ton of different procedures, and there's a subset of pain too that is really procedurally focused on, different epidural injections, things like that. Much more extensive variety there as well. So a large, the field has medical components to it. There's also a decent amount of procedural component that you could incorporate into your practice if it interests you.
And in residency, you get exposure to all of these different clinics, and including peds and complex care clinic, equipment clinic, orthotic and prosthetic clinic. So there's a lot of different things and a lot of different clinics that you'll be able to participate in and throughout residency and kind of get experience in.
And I think a lot of this is also kind of illustrating the continuity of care that you can have with patients, right? Mm-hmm. Awesome. Well, one more question within the realm of, just introducing the field, and then we'll kind of speak to some of what are the things that students can do to get involved. But just to end, what type of, what are your biggest challenges? What are your biggest rewards with working in PM&R?
Yeah, so I love my field. It's really rewarding to, I get to work with very, acute injuries, some very severe brain injuries, disorders of consciousness. So getting a chance to see somebody sort of go through the recovery process is extremely rewarding. And I do mainly inpatient, but I see outpatients as well for that continuity. So I really get to see somebody over years get better and get back to the things that are important to them and return to their life roles. And so it's a wonderful field as far as like the rewarding side of seeing people get better. And you work closely with the families too, which is also a rewarding relationship. Like it doesn't not just you and the patients, you, the patient, and the family. I would say the challenges really have to do with systems. Like our healthcare systems are deeply flawed, and I think for many physiatrists that would probably, it's the thing that is the most challenging, is sort of navigating our healthcare system and its inadequacies.
I would echo what Dr. Russo says. You can tell which of us are attendees. We both have very similar experiences, even though we're doing different things. I think one of the most beautiful things about PM&R is the relationships with your peers, relationships with your colleagues that are in different fields completely in terms of therapists, nursing, social work, and then the patient and the family obviously are integral. And so that's one of the most rewarding things, as well as this kind of mixture of procedure and medicine that we just talked about. It can be hard to see an individual that has definitely a devastating injury and has a long road. But then when you can do a suprascapular nerve block or a Botox injection and have some significant improvement in their pain or quality of life, it's just a nice, like, okay, yes, we got to win today, and so I think that's what's great about the field. I think what the challenges are is definitely, as Dr. Russo said, is sometimes the system that we are within it can be quite challenging. Uh, one just example in spinal cord injury, if you were paraplegic 20 years ago, you would probably get 2 to 3 months in acute rehab. Now you'd be lucky to get 4. And so it just becomes much tougher, obviously, to get what someone learned in 3 months down to 2, down to 1. And so that's what we're kind of working against, is how can we, achieve as much as we can for these people.
Yeah, I forgot to mention the interdisciplinary joy. It's a wonderful field as far as like getting to have like this whole group of different disciplines that you get to work with very closely. My relationships with the therapy teams and the nursing staff, it's really part of my day that I find like really rewarding, particularly if it's been a hard day. Connecting on a patient progress with people I love to work with is definitely a plus plus.
Even though I'm just a PGY3, I definitely would agree that the insurance issue and just like the systems in general has been very frustrating to learn as a resident, because it's not really something that you pick up on an away or even elective in PM&R. So it's difficult just because as physicians and residents, you want to help your patients as much as you can. And it's just very frustrating when everyone on the medical side and the therapy side wants to essentially, like, for example, like extend the stay or work on some things, but just because of some specific, very almost random markers, the insurance says no. So it is sometimes very frustrating from that standpoint, but I still think PM&R is, I mean, I'm biased, obviously, I'm a physiatrist, but I feel like it's one of the most rewarding specialties, and that's why I ultimately chose PM&R. Even I think all aspects, whatever field, specialty, subspecialty you end up doing in PM&R, it's all aspects are just so rewarding, just because I feel like we deal with function, and just seeing the patient improve in XYZ function is just very nice. And we do get that continuity of care if that's something that you seek as well. So yeah, I think pros and cons in every field, but kind of figuring out what cons that you're able to kind of live with is an important thing in choosing specialties.
And not to backtrack at all in terms of the con, but I will say, what's nice is that aspect of, if you're doing inpatient and outpatient, you get to, if you do get that con of, oh, I wish we had another week to get these things done. Luckily the story's not ending, right? And so you get in residency, it's kind of hard, I will say, because you don't get to see that, and so you just see oh, we got one less week than we wanted. But luckily, on outpatient end, you'd end up seeing, okay, it took a little bit longer than would have been desired, but we still got the job done. And so
Also, some physiatrists are pretty fun to work with. Like, it tends to be a really empathetic and like kind and whole person field in general. So I think the people it attracts to your colleagues tend to be pretty awesome people to work with. Really very caring group and human, because we work with, you know, a person in their entire context. So I think we bring that to our work as well.
Yeah, that's a great point. Well, if any more questions come up specifically about like what is PM&R, I encourage any of the participants to go ahead and throw things in the chat. Just to keep on time, we'll just move on to some of the questions about what students can do to get involved in the field, particularly early on. So with that, what are some extracurricular or volunteer experiences that you guys feel are valuable for someone interested in PM&R?
I think getting involved with your campus's PM&R interest group, there's a lot of opportunities there. Getting involved in adaptive camps and sports, and then any sort of volunteer opportunity that you can get, even volunteering at like the national level through the associations that we have available.
Yeah, I would echo that. Just I think PM&R is a rapidly increasing interest, which is, I love to see it. It's a completely different landscape than when I was applying. I wish I had found out about PM&R way earlier. I would have done more, I feel like. So yeah, I feel like just getting involved, trying to shadow if you haven't started clinical years yet, and shadowing in all settings just to get a good overview of all the different types of physiatrists out there, because we are such a large, comprehensive field. Like a pain physiatrist's day is probably very different from an inpatient SCI attending. So lots to see.
Echoing what the others said, adaptive sports also definitely did wheelchair basketball and rugby with my local wheelchair sports organizations. Anything with underserved populations. There were some free clinics in town that my school was associated with, but they also had some MSK exposure as well on like certain days. And so being sort of creative with what's around you, I think that's always a good thing to do, involved in different organizations, AAP, AOC, PM&R for your DO, and other, those organizations are good to get started, build your resume with, but also really good mentorship and networking. I think having medical students to help guide you and other peers as support is really helpful, that I found really rewarding. And then going to conferences if you can, if you have like a piece of research to submit an abstract for. It's a good way to get getting out of this early, and going to these conferences are really fun. So if your school is able to pay for it or you're able to fund it, I think that's super fruitful and motivating to surround yourself with people that are like-minded, but also learn from people, maybe people across the country. I think it's super rewarding as well.
Yeah, it feels like sometimes the classic volunteer experiences are those like adaptive sports or working with patients with disabilities. But again, what I'm kind of hearing echoed is just like working with people. And I know that's very broad, but I know some, students have come up to me and just asked things that I've done. And I think it's like really making sure that you're doing things that you're passionate about when you're choosing volunteer experiences, because that's ultimately what will carry through. So no need to overthink it too much, right? We touched a little bit about research. I know that's always a kind of hot topic when we're talking about thinking about residency and everything. How important do you guys think that research is for applying to PM&R? Doesn't matter what type of research that students do.
I think it's one of those things that research is never going to necessarily be a bad thing, right? But is it a necessary thing? I don't think so. I think it goes back to what we just spoke on. I think the key thing when I'm looking at applications and things like that is, what is this individual's experience? Why are they interested in PM&R? Did they, just do one adaptive clinic, and then all of a sudden they're applying to PM&R. You know, the story has to make sense, right? And so whatever story you can tell with your activities, research, or volunteer is what individuals I think are really interested in. And so in terms of research, sometimes it's hard to get research. PM&R is a smaller field, and so I don't think it's necessarily, you need to have a double-blinded, prospective study that you did while in medical school. But if you even, say you're on a neurology rotation and they've got a case report on an interesting stroke syndrome, write it up as a case report, and potentially one of the PM&R residents is already interested in it. And it's one of those things that if you even start that kind of communication, the resident is going to love you. They're going to say, oh, well, Dr. So-and-so brought this case to me. We're going to work on it together. And, it just kind of builds that connection, and as well as your experience in the field. So I think research, obviously, if you have something specifically in a spinal cord injury, that's fantastic, mainly because you're advancing our field. But if you don't, and you have something on urogyne somehow, well, the bladder is affected in spinal cord injury, as long as you can kind of convey it in a manner that shows, this is kind of what I came across in my training, but I had interest in spinal cord injury or in TBI or whatever, MSK, and that's how I kind of so-called spun it. And so I think it just depends on what story you're able to convey with your experiences.
Yeah. Yeah, I agree with Dr. Brahmbatt. But so when it comes to research, so when I'm looking at an application, I might note that you did molecular biology research as a undergraduate and say, okay, they've had some exposure to, these types of things, but it is by no means necessary. So I think what Elise mentioned as far as passion goes is very important. So whether you volunteered, whatever it is that you did with your time outside of school, if it was important to you and you can talk about it in a way that is passionate, that's more interesting than I kind of found this one thing that I needed to do because I felt like I needed it for my application. I would also agree that one of the things we are looking for is when you're applying to a field that you do understand what the field is about. It doesn't have to be details, but you have some idea of it's not just sort of outpatient MSK, but there's this whole breadth, because during your residency, you're going to work through each of the fields, no matter where you ultimately settle. And you will be most happy if you are, ready and willing to have the experience of kind of moving through all these different parts of the field. So I was always, when I would, as a resident, interview medical students, I was always interested in what were their exposures. Did they have, what was the breadth of their exposures, and did they have like a general understanding of what the field might encompass, was much more important to me than if they did the right research. Again, as Dr. Brahmbatt said, not every place has opportunities to do the correct research, so it's not expected.
I wanted to add, and thank you, Dr. Russo and Dr. Penn, for that. I think as a first and second year, I think number one is focusing on your classes and what you can do well in. I think that's to take some pressure off you guys, because I know it's quite competitive. But I saw research as twofold. Something in third year, you get case reports, you're working with doctors. It's a good way to network and just to learn whether someone's a urogyne versus I did a case report in emergency medicine just because I thought it was interesting, but to learn from those residents, fellows, or attendings, to learn about the research process, to learn how to accumulate references, what are high yield. So I think there's learning in that, and it's a stepping stone to one. At some point you'll get something PM&R related, hopefully, but if not, it's something you could speak on in an interview. And so, I learned these analytical skills. I framed it as, I use it as a way to network and to just work with people that I enjoy working with. And it was a great to get to know people. So I framed it as a twofold thing, academic, but also professional and mentorship. They may help you with apps and how to go through interviews. So I saw it as research is not just a check mark, but it can help you in many aspects of your application and life, and you'll still hopefully connect with some of these individuals.
Yeah, that's super helpful. I'm hoping that this perspective that we've collected from the attendings and the residents can help everyone just like take a little deep breath, because I know I want to validate that it can be stressful to think about all the things that you need to do to get into residency. But again, if you're following your passions, if you're reading about your patients and that ends up turning into research, then you can't go wrong. With that being said, I would be remiss to not also mention the medical student research program that the AAP does have. So I put that in the chat there if students are interested in just kind of looking at one of the opportunities that you may have through the AAP. Great. So what type of skills or personality traits do you think, I know we kind of answered and touched on this, but what are the personality traits that kind of help someone thrive within PM&R? And what would you look for in say, a resident or a prospective student interested in PM&R?
I think definitely passion for the field that's been echoed, and not just like a singular aspect of the field, but the field in general. And at least having a good idea of what that all entails, even if maybe it's not complete, or knowing that there are these other areas in PM&R and that we're really focused on the whole person. And then also that empathy.
That was what I wrote down, was empathy when I was looking through these. As like it's a primary trait. There's many others, but I agree with empathy.
I would say a big trait is communication. I think with the interdisciplinary aspect that we have in our field, you have to learn and have that skill set of being a good communicator to be able to communicate with and work with a variety of different colleagues, as well as being able to communicate to your patients. Oftentimes we see a wide range of patients from all kinds of socioeconomic backgrounds, and so you need to be able to summarize things that have happened in a very simple manner, so that they don't get stuck on nuanced things, and you can help them through that process. So I think communication is really key, and being an individual that can help with kind of guiding them to that potentially distant goal. And so I think being optimistic is also a pretty significant trait to try to have as a physiatrist.
Yeah, then when I've had students rotate through for their sort of their tryout, there are some aspects that we're looking for. It's integration into the team. How well does the student sort of jump in and figure out ways that they can help and be a part of the team. Looking at their interactions with patients, are they able to build sort of quick rapport? Are they warm? Do they have the ability to kind of connect with people? Because we do a lot of connecting, as Dr. Brahmbatt just kind of alluded to. Humility, because again, we are definitely a member of a team in physiatry. Like we are, though we have sort of the overview for the patient's care as the attending of record, we're still very much a part of a team and need to feel equal with so that everyone we work with. General enthusiasm is always good. Just to feel it's the person who's there, trying out is really genuinely interested and excited about the field. And again, that there's as Dr. Landry said, like a broad, they have sort of a understanding that the field, this sort of size and scope of it, without, again, details aren't necessary, provided there's kind of a full understanding. It is a field, and I think the plenty of money and rest thing, I think there is the misconception. I think that it's a lifestyle. And so I think understanding that in different forms, it can be very busy, and that's an expectation coming onto PM&R rotation. It shouldn't be that like, okay, great, I get to chill. Like, it's like there's a lot to do. It's hard work, and it's serious too. Just in any time we're taking care of a patient, and we have it's a big responsibility. So to the understanding that it's not just sort of it's not going to be a relaxation ride to do a PM&R rotation.
Yeah, and I would just echo what has already been said. I think all of the points that I was going to mention have been mentioned, like empathy, team player, communicator, and just overall respectful, kind of like the simple things that you would think of. Knowledge-wise, I don't really expect in a way or any elective medical student to be able to explain the entirety or breadth of continuum of rehab. Like that's why you're here to learn. Even like as residents, we're here to learn. I don't necessarily like will dock someone on lack of knowledge, but I really appreciate when, because you can tell when a med student is interested versus uninterested. So just interest, compassion, students who want to, I don't know, shadow therapy when I'm busy doing notes or something. Like you can just tell when someone is very interested in the rehab aspect in itself. So I think just all of the things above, seeing if you're a resident or you're attending any articles, anything that they could read up on just to learn more about the breadth and care of all the different types of patients we see on the inpatient side. Because I know sometimes as med students, it's hard. I think every day in our rotation is a different day for them. So it's a lot to take in. It's a lot to learn, like disorderedness of consciousness one day and then how to do an INSCI the next day. It's like, it's a lot. So just kind of learning as it goes, and just, yeah, being pleasant and respectful to everyone.
I don't think I've met a single physiatrist who is not approachable and willing to talk to you about the field. So that if that sounds like you, then maybe you're a physiatrist.
And I don't know if we're gonna answer the questions in the chat later, but I know we're running out of time. If it's okay, I think we can answer Kaufman's question of what to do if you don't have a home PM&R program. You know, that's not a rare thing. And so I think, you know, as Dr. Du stated, those are great options as well to do. But the other thing is, you know, this is where OAs can definitely become helpful, and in allowing you to get that experience that we're talking about, right? I think, well, you know, programs struggle to see applicants when they've had very little exposure to PM&R. Because the reason why is not because we're trying to be biased against those individuals that have low exposure, but the concern is you don't want to get an individual that comes into a residency program thinking PM&R is plenty of money and relaxation, and then be surprised that it's a little bit different. And so doing away can be something really helpful, as well as going to conferences. I think conferences are a very fantastic way to get a really wide breadth of exposure to PM&R, because usually our big conferences are not going to be just teaching neuro rehab or just teaching pain. You know, you're going to see lectures on peds, you're going to see lectures on TBI. And so I think it's a great place to get some exposure. There's a lot of them will have specifically scholarships for medical students, and so it doesn't even need to be a big monetary burden for medical students to be able to get that exposure. And then obviously with the networking that can occur at those types of conferences is going to be huge as well.
Yeah, I think attending conferences and meeting people, I've not met a single person who hasn't been like, no, you can't come work with me, or there's this barrier to being able to communicate or contact somebody. I've had people reach out to our program through Instagram, and we've brought them in for a week in their first year of medical school because they're like, I think I might be interested in this. And so they came and they shadowed for a week, and now we have kind of ongoing communication. They're helping me work on some presentations. So again, physiatrists are very approachable people. Reach out and get to know the field.
And then events like this too, it's like even if you can't go in person, both the AAP and AP&R, they both, or I should say even that, just the AAP, just gonna have like offer a lot of virtual offerings that can help also increase exposure. There may be journal clubs. There's all kinds of materials online. So I would look into those opportunities too as a way to kind of get increased exposure. And again, it can lead to people that you know reach out to say, hey, can I talk with you more?
Elise, can you maybe also drop the Big Buddy or Little Buddy program? I forget what it's called in the.
Yeah, I was going to mention, I think there's a mentorship program for AP, something buddy. And then I don't know if there's any DOs on here, but AOC PM&R also does something very similar for mentorship. And I think away rotations, my med school did not have a home program. So my first inpatient rotation was on my away. So if you have the opportunity to do that, definitely look into that as well.
I went and dropped what is the Google Doc like sign up sheet for the Big Buddy program. It does have a little blurb on there that kind of explains the purpose and utility of it, but essentially it matches just students to residents to students to each other, just based on some interests, and that can be very broad, like geographic, like commonalities, PM&R interests, all this stuff. So I highly encourage joining. I have been mentored by Big Buddies, and then also have now had the chance to be a mentor. So it's really rewarding and a good chance to start networking as well. We do have a question in the chat. Parker asks, how can I formulate my application in a way that sets me apart? I feel like I'm the same as 80% of applicants. Sports background, had an injury, worked with physicians and physical therapy, and this got me interested in PM&R.
This is like exactly also my application, so I very much relate, but I think just to echo what we've kind of already talked about is just your passion for the field and really being able to explain in your personal statement and in the future, if you get an interview, why you want to be a physiatrist and be able to fully kind of like coherently explain that very well. I think it'll shine through in both your application and in the interview. And not to really, I wouldn't worry too much about like all the details, because I think it'll all kind of play a part. I feel like PM&R being a very holistic field, I think it also looks at applications very holistically. So just really kind of trying to figure out your exact reason and passion for PM&R, and I feel like that'll kind of shine through.
Awesome. Well, in some of our last time, I kind of want to just have like a closing question of anything that you guys would do if you could go back to medical school, just in general, or to better prepare yourself for a career in physiatry.
No, thank you. I would not go back to medical.
Pay more attention in anatomy lab.
Yeah.
Not just see it as things that need to be memorized and then dumped for the next test to memorize again. So
I would say something with, you know, med school, a lot of these things in your life you only get to do once, and hopefully you don't have to repeat or anything like that. But the time you have with your classmates, maybe the times that you may not spend with them again, and you may not have reunions as much as you want. So enjoy the moments. Very strenuous, and I think that it's okay to go to that dinner with your friends, even though you have a test on Monday. These memories, these people that you meet, you'll be friends with for life. You're connected for it's a tough time in your training, but just like college and pre-med and med school and beyond. Try to live in those moments, make time for what's important for you, friends, family. Because at the end of the day, when you look back at med school with your classmates, you're not going to remember a certain test, but you remember what you did and the memories you made, if they're fun or not. And so I think just live in the moment as much as you can.
Enjoy the process because you do only get to experience medical school once. The one thing that I kind of put down is would be getting involved sooner in kind of these national organizations.
Yeah, I agree with Dr. Landry. I don't think I had as much awareness of the breadth of the potential involvement at the medical school level in the national scene. So that would probably be the only thing I would do a little bit differently. Yeah, it ends up working out. I mean, if you get as much exposure as you can, like I said, to get to the field, to sort of get the full sense of what it is, it doesn't have to be deep exposure, just to kind of really understand it, I think is reasonable. It looks like there's like a question in the chat. It's very similar. The PM&R elective responsibilities of medical student, it's pretty similar to internal medicine. Like our service is inpatient. If you're on an inpatient rotation, it's medically active service. So we're managing a patient's, they're in a hospital setting. So it's pretty similar, I would say, plus except add in like the interdisciplinary stuff that you're liaising with the therapy teams as well and getting their information, not just the kind of the labs and the vital signs.
So one of the things that I always add when working with medical students is focus on that. What were we doing before we were hospitalized? What are our goals? What do we want to get back to once we leave the hospital? That whole quality of life aspect that you don't touch upon in internal medicine, because yes, we are handling other things, but making sure that that focus and that understanding for that part is also there.
Yeah, as a medical student on these rotations, when you come up with your plan, I have gotten the feedback of like, oh, that's a great medical plan. Good job. Now what are we doing for rehab, and what do they like to do outside, and how are we going to get them to that goal? So I think that's like the funnest part, is that you use all your strong foundation in medicine, but now you get to start thinking about the patient and what they like to do and making that all make sense for them. Well, we just have a couple minutes left. If there's any questions that people want to unmute themselves or throw in the chat, I do want to just respect everyone's time and make sure we get everyone out here by the top of the hour. And I'm also going to put in just the AAP website. I know you can get to it through some of the other links I put there, but as it's been mentioned kind of multiple times, being involved in leadership opportunities or national institutions or organizations can be really helpful to just network, expand your awareness of the field. And typically the MSc applications and elections and everything go on towards the end of the year. So I would just put it on your radar, look for those deadlines, and highly encourage everyone to apply if you're thinking of it. And then, yes, thanks, Amy. So obviously this is a webinar, part of a larger series, and we're gathering just information, feedback, survey for participants. So if you have a minute to just scan the QR code and fill out those surveys, that would be super helpful. I want to also just extend a very sincere thank you to all the attendings and the residents for volunteering their time during their evenings for this event. It's really special, and I think it speaks to just sort of the mentorship and the approachability of the entire field. So we're really lucky, and I'm excited that you guys are all interested in the field. I think it's really cool to see how much it's growing among medical students, and I'm psyched to be a part of that. So thank you all so much for coming. Thank you to our volunteers. We really appreciate you guys.
Thank you all for setting this up.
You bet.
Thanks,
Thank you.
appreciate it.
Thank you. Bye, guys.